Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Ford, and I'm the chair and organizer of Grand Rounds for a little while now, but not as long as I've known today's speaker. So Mudher Al-Khairalla is one of my best friends, and I've known him since 2004, I want to say, when I think I was a research fellow and Mudher was an SHO, and we met in the East Block seminar room, and we have been friends ever since. So it's always a delight to have him along to any meeting, but particularly to come along and speak at Grand Rounds. Mudher is from Iraq originally. He spent some formative years in Yorkshire, not too far away from me. Not that we knew about each other back in the 1980s and 90s. And then he moved to Dundee to study medicine and has never, and is still here. But in the interim, he's been back to Iraq. He's worked extensively with the Iraqi government post-war to rebuild the Iraqi healthcare system, particularly in respiratory medicine. He was instrumental in setting up respiratory training, respiratory hospitals in his home area of Nasiriyah. He worked in Doncaster, back in Yorkshire, for a number of years, and has finally settled living in the lowland of Perthshire, working PRI for some of the time, in Iraq for the rest of the time. Most of us who know him have absolutely no idea how he fits all this in. There is extra hours in the Mudher day. He works tirelessly for his home country in Iraq and for he's going to talk about a clinical approach to chronic consolidation of the lung, including non-resolving pneumonia. Mudher, thank you so much for everything that you do and for volunteering to speak at Grand Rounds. I appreciate you, and looking forward to it. If you could mute your microphones so that we leave the space to Mudher, and if you have any questions, put them in the chat, or you can have a question and answer at the end. I think Mudher's roommate is in the throes of an interesting conversation in the background, but I think we should be all right once Mudher starts talking. Thanks again, Mudher. Well, looking forward to your talk.
Right, love you too, Tommy. Thank you kindly for that really kind and warm introduction. My colleague and other friend of ours, Pete Williamson, who we share an office, has got another talk with AMPs. I think he's on call today, so I don't think it'll be long before he finishes. Tom, you mentioned that we've known each other for more than 25 years now. Some people might call that a life sentence, but I've loved every minute of it. And yes, you're right in terms of having lots of energy to do a lot of that. And I think it's, I guess, giving back something in terms of how you can make your job a bit more recreational, and that's what keeps you going. You wake up in the morning and you're looking forward to doing more of what gives you purpose in life, I guess. I chose this topic for a number of reasons, and I think it's I've been thinking as I've been growing younger about the art of medicine, and I thought I would choose a topic where I can apply that that art of medicine in practice with a clinical approach to chronic consolidation of the lung, including non-resolving pneumonia. Now, I think all of us, Tommy, is the background noise too loud? I don't know what to do. Or can you hear me okay? Can you hear me okay? Oh, he's gone.
Mudher, it's fine, it's great. It's Dave here.
Oh, okay. Okay, hi, thanks, Dave.
On Tom's behalf, it's fine.
Thanks, Dave. So the art of medicine is an art where we have basically doctors trained as undergraduates and postgraduates. Essentially, we train from a very early stage how to make diagnoses. And as the years have changed, and those who are almost dinosaurs like myself remember that there was a sort of change in the way that we educate medical students in terms of how we approach and try and identify, disentangle, like a puzzle, what a diagnosis is. Instead of learning in a didactic way what, say, for example, Waldenstrom's macroglobulinemia might look like, we do it in a different way. A patient presents with A, B, and C, what we call a grey case, and then you put it together and you come up with a diagnosis. So that's true for undergraduates and postgraduates, and then everything should follow. So you get people with expertise. So you've just heard Dave, for example, who has expertise and a specialist interest in infections of the lungs. So then what happens is that people with expertise will start putting together things that would help guide everyone else that have come to a diagnosis in terms of putting out guidelines, putting out pathways, putting out protocols that those who've worked hard enough to reach the diagnosis can then implement some of those in the case of a patient. One of the things that I'm also going to sort of touch on as well in terms of medicine is the lovely thing about doing general medicine with a subspeciality is that not only you have to master the art of medicine, but more importantly is how do you address a clinical case where the patient's either improving, believe it or not, but you're still not comfortable with it, or the patient isn't improving, which is a more common scenario. And what can you do and how could you sort of develop the skills that then you could look out for, okay, so I thought that was a diagnosis, but the patient's not getting better. What is it that I can do differently so that I can approach such cases? And that's when it comes to chronic consolidation of the lung or the non-resolving pneumonia chat. So that's the intro bit. I'll talk a little bit about what the expected resolution of pneumonia is, the evaluation that we try and do as respiratory physicians and internists before the respiratory physician gets involved, some of the common bacterial pathogens that and their influence, the initial complications, and some of the non-infectious differentials that are quite crucial when you have non-resolving pneumonia. So I'll start off with plurality should not be posited without necessity, which is Occam's razor, as if people might recognize that. And basically that there are times when we don't shy away from having a unifying diagnosis. So a patient comes in, they've got a lot of symptoms, a lot of signs, and it's amalgamating them all into a unifying diagnosis. That I think happens when you've got an issue, particularly related to internal medicine. That's why quite often you find people like myself and many others strong advocates for engaging with internal medicine, acute and selected and otherwise, because then you maintain that skill of having exposure to other aspects of medicine that's away from your speciality, because then you're more likely to be able to amalgamate it all into one particular diagnosis. And it's things that would affect you systemically. So infections can, something like tuberculosis, for example, or vasculitis, etc., etc. And then you've got the other side of it, where patients can have as many diseases as they damn well please. It comes dictam. And you see this when patients are allowed, as with the general population, to have another problem on top of the existing problem. And you have to be wary with people who've got chronic ailments. So if they've got chronic diseases, say, for example, bronchiectasis and COPD, you always have to bear in mind that their breathlessness could be something else, could be a metabolic-driven component like anemia, could be a cardiac dysfunction because they share common risk factors, COPD and cardiovascular disease, etc., etc. So you just have to be wary that they can have more than one explanation. And it's a balance of those two when you're approaching a patient when they're not getting better. Consolidation. So to consolidate something is to make it solid or stronger. So, you know, the working in a sort of collegiate, compromising collegiate way it can make us solid, can make us stronger. Not necessarily what we're seeing in the political landscape at the moment, but that's the idea of it, and that's where the word consolidation comes from. And in the lungs, it's basically when the normal air sacs, the alveoli, are filled with products of disease, whether it's fluid, whether it's blood, whether it's pus, whether it's acid, whether it's solid, etc. Then we call it consolidation. And you've got a good example of that here that you can see on the screen. Often it's heterogeneous rather than homogeneous, and you can see that there's an opacity here that's denser than the surrounding opacities, and that attenuation that you see there on the chest X-ray. And this is a case where the patient wasn't, this is an acute setting, an inpatient setting, in about 10 to 15% when it was diagnosed with pneumonia. The CRP was failing to drop by 50% in a space of 72 hours. And that's when we defined it in the acute setting that this is a non-resolving pneumonia. Sometimes CRP can take a little bit longer. Sometimes CRP can take Sorry, I don't know why that's ringing. It shouldn't be ringing. 2 seconds, let me just switch this off. Right, apologies. So the CRP falling by 50% in 72 hours, or not falling by 50%, would you think there's a non-resolving pneumonia component here. Sometimes the clue to it isn't necessarily the CRP, and I'm not advocating for repeated CRPs unnecessarily. It might just be swinging fever or sweats and systemic issues that the patient's suffering, that then you might think, well, that patient's not getting better. There are a few reasons why. Either they've developed something suppurative, like parapneumonic effusion, or there are resistance organisms. So say, for example, somebody who come from a holiday in Spain, they've got atypical pneumonia and you've given them a macrolide, they're not responding, and there's high resistance there. It could be the route of antibiotics, or something suppurative might need parenteral treatment along with an intervention that might clear them. And outside pneumonia, there are some infections such as discitis, for example, endocarditis, etc., that would have to have parenteral route. Other differential non-infectious, you find them in about 1 in 5 patients. This is in the acute setting. And you start thinking about that when the CRP is pretty high, 200 plus, for example, and you have a low threshold for imaging them, and quite often hematological malignancies would come into a differential like this. There might be an additional alternative diagnosis. So it's either they're having a pulmonary embolism, for example, or additional, because sometimes pulmonary embolism can cause an infarct, and that's what got infected in the first place. We'll show it later, what we call Hampton's sign. And that gets infected in the context of underlying PE. And there are patient factors as well that we'll allude to, we will sort of touch on in the rest of the talk, that sometimes makes people take their time to recuperate from an infection. So in the context of a chronic picture, so a non-resolving pneumonia that is chronic or chronic consolidation, it's a pneumonia that progresses or resolves very slowly, or is persistent after 6 weeks. Then we call it chronic consolidation. I'm not going to go into detail about CAP and HAP and VAP and immunocompromise. It's just the concept of the consolidation taking time to resolve, rather specifics of those types of pneumonia with an infection theme. You'd expect resolution of pneumonia in about 70%, they'll be back to their baseline within about a week. 70% back to their baseline within a week. And you could also assure them that a lot of them will take a little bit longer to get back to 100%, usually about a month and a half. And resolution of the X-ray often lags behind, and that's a common knowledge to all respiratory physicians, which makes us panic less when we see the X-ray is still persistent. So it usually should take about 4 or 6 weeks. It can take a lot longer, 10 weeks if it's severe CAP. It can be a bit more rapid in uncomplicated pneumococcus, mycoplasma, and moraxella. It could be less than 4 weeks that you'd see improvement, but you're still looking at weeks rather than days. If you find stigmata of clinical malignancy, so for example, the patient's got finger clubbing without other explanations, so plevoclin node, and they're a smoker, then you should lower your threshold to consider underlying malignancy in addition to the pneumonia that you'd be treating. So that should expedite the investigations. 6 weeks rather than 4 if you're above the age of 50, which I'm coming up to, and if you've got significant comorbidities. These are usually comorbidities that can impair your immune defenses either directly or indirectly. And I've put here, and I'm happy, and I think it's all recorded anyway, so feel free to go back to this busy slide that basically puts some conditions such as COPD, alcohol use disorders, neurological diseases, etc. And when do we expect malfunction within the immune system that might delay recuperation when it comes to consolidation in the context of pneumonia. Sometimes what happens is that when you evaluate people in non-resolving, you need to do a few more tests to try and find out why they're non-resolving. It could still be infection, but it might be something else. So reviewing the current and previous history is crucial. And I can't, emphasize that more. A patient might tell you, oh yeah, I was admitted with pneumonia twice last year. So either they've got an impaired mechanism, such as a fistula, for example, because they've had a long-standing procedure before, say upper GI surgery, or they might have a condition like COP, where they're having recurrent sort of bouts of what we've been treating as pneumonia, but it's actually non-bacterial pneumonia. You need detailed imaging, so people will get a CT scan. You need sampling, and that's when you might need your respiratory physician, your thoracic surgeon, your interventional radiologist, and the samples differ. It could be VATS, it could be CT guided biopsy, it could be endobronchial ultrasound, it could be cryobiopsy that I do in Iraq, for example, and I think they do it in some centers here. You get transbronchial biopsy, which people are now shying away from because you've got more definitive modalities that give you a higher yield for the high risk associated transbronchial biopsies. But sometimes you do need histology in some cases where you're thinking it's non-infectious etiology. Microbiology, wash, bronchoalveolar lavage or a bronchial wash is what you would hopefully obtain, particularly when you're looking at getting a wider sort of culture and sensitivity for some bacterial pathogens, mycobacterium or non-tuberculous mycobacterium, and fungal diseases. And people who specialize, who've got a special interest in this, often put a lot of attention into getting and obtaining these samples because they're crucial in terms when it comes to treating the patient long term. Systemic or acquired immunodeficiency, so systemic issues with the impairment of your immune system, like acquired immunodeficiency, HIV, or vasculitis, is also something that you have to consider in terms of other investigative modalities when you're trying to consider why the patient's not getting better. This was a 33-year-old chap, and you can see that he's got heterogeneous opacification in the right upper zone with well-defined demarcation above the median fissure. So this is lobar pneumonia because it's sitting in the anterior subsegment of the right upper lobe, albeit two-dimensional structure that I'm showing here, but that's where it is. And it fits with somebody who's got type 1 diabetes, swinging fever, and rust sputum, likely to be pneumococcal. So if it's quacking like a duck, go ahead and treat. But if it's less quacking like a duck later when the patient's not getting better, it could be they just need a bit of time, or it could be the acronym that I'll be using later to demonstrate what we need to think when the patient's not getting better. In terms of specific bacterial pathogens, it's helpful to know some of the patterns. So I think guidelines, and I'm sure colleagues in this call, in this meeting will correct me if I'm wrong, but I think a lot of the guidelines historically have mainly focused on CAP and HAP, less focus on anaerobes and fungal. Strep pneumonia is the commonest by far to cause CAP and responds favorably if there are no risk factors. Legionella infection, risk of Legionella is the same as those for delayed resolution, so smoking, alcoholism, 65 and above, those who've got transplantation and immunosuppression because of it, and those who've got chronic kidney disease. So these people will take a little bit longer to resolve. And the radiological resolution lags behind compared to the others with about 10 weeks. But hopefully by that point, you would have made the diagnosis of Legionnaires, and then you're anticipating what the recovery period is going to be. Mycoplasma is a common respiratory tract infection, but rarely severe, thankfully, and it's got a quicker resolution. 1 or 2 weeks, you'd expect complete resolution in terms of symptoms, 2 weeks or thereabouts in terms of consolidation on the X-ray. Haemophilus influenza is a common lower respiratory tract infection. When we say lower respiratory tract infection, we're talking about anything below the vocal cord. So vocal cord and above is upper respiratory tract. Below the vocal cords, it affects the bronchi, bronchitis, if you like, is lower respiratory tract infection. Anything that goes into the parenchyma is pneumonia, which is also a lower respiratory tract infection. So you see it in those of 65 and above, smokers, those with underlying COPD. There has been a reduction in incidence when Haemophilus influenza type B vaccinations rolled out in kids, and it's slightly slower clinical resolution, 50% at baseline in about 6 weeks. So you bear that in mind when you're looking at it. There are sometimes misdiagnosed pathogens, so I'm going to touch on briefly on those. The idea of the talk is more a general overview of thinking about these things rather than discussing them in detail. So if somebody's 65 and above, they're an immigrant or an expat coming into the West from an endemic area, and those who have HIV, and you've got slow resolving consolidation. There's a good picture of the CT scan here when you see there's also cavitation within that consolidation, then think Mycobacteria tuberculosis. This one was a case where they had what looked like early cavitation as well on a background of COPD bronchiectasis. People with HIV are at risk of that as well. And you can see that within the right middle lobe, there's some cavitation consolidation there, which you can get with non-tuberculous mycobacteria. And that's a talk in its own right, of course. Fungi, you have to consider them when you've got immunocompromised individuals, evidence of vascular invasion and cavitation. And you get this halo-like sign around the dense consolidation when you're considering fungal infection. Nocardia, you're going to capture it with a wash, to be honest, because ultimately you're going to get consolidation. Sometimes you get a bit of cavitation in those who are immunocompromised. That should lower your threshold for doing a wash to differentiate between mycobacterial tuberculosis, non-tuberculous mycobacteria, fungi, nocardia, etc. Actinomyces, I've had a couple of cases. I see a lot more of this in Iraq, but I've had at least a couple of cases that I've seen here in Perth. I don't know about Nine Wells, where patients develop quite dense consolidation with what looks like gas bubbles. And it sometimes sort of invades into the soft tissue as well. One case we had, the reporting radiologist made the assumption that we'd tried to take a sample from the patient, and that's where you could see the gas bubbles. But he hadn't had any sample. It was gas-forming organisms. I think that patient had Staph aureus, actually. And you sometimes get with actinomyces and others where you get a sort of quite dense consolidation that invades into the chest wall. And the clue sometimes is they do have features of underlying infection, pneumonia, and also often these patients actually have associated risk factors for malignancy. So it should always remain in the differential when you're looking at these people. That's just for reference. Again, this is recorded. It's a busy slide. Is sort of risk factors or associations between every single organism that I put there. So, for example, Coxiella burnetii, Q fever. I think I've seen a couple of cases in my career. It's people have been exposed to cats, cattle, or sheep. Leptospira when you're exposed to rats, or people that work within that industry, and so on. So I've left that for people who want to reference it, but it's helpful to know when you do have a case and you're thinking that it could be something unusual. Resistance bacteria is, of course, a big, massive topic that we all need to be interested in, because it's not necessarily heading in the right direction, albeit with all the advents of pharmacology and pharmaceutical industry trying to reduce that. Antibiotic policing, from my experience anyway, is really tough in the Western world. Sometimes it sounds very negative, almost impossible, when you have poor regulation in the private sector and the pharmacies around it. In Iraq, where I work, I don't think it's challenging as some parts of Eastern Europe, but it is a big, big issue. So, for example, in Iraq, you're not allowed, by law, you could get into big trouble if you're dispensing anti-tuberculous drugs from conventional pharmacies. It has to be through state-funded institutions, and that's one way of protecting us from resistant patterns, etc. Meropenem and imipenem and those types of drugs also need counter-signatories so that we could justify them when we give them to patients. Any pathogen could be resistant. So pneumococcal penicillin resistance would be the most concerning because it's the commonest culprit when it comes to pneumonia. There are other organisms that have emergence of resistance: Haemophilus influenza, unfortunately Pseudomonas aeruginosa, and of course Staphylococcus aureus in the form of MRSA. Host factors, there are general host factors: alcohol misuse, 65 and above, diabetes and macrophage dysfunction, COPD. Acquired immune deficiency syndrome, pneumonia, and PCP in particular are ones to watch out for, particularly people who haven't been treated or diagnosed yet. And then there are a large number of primary humoral immune deficiencies, like common variable immunodeficiency, that is crucial not to miss if people have recurrent pneumonia, because it's treatable and they are more at risk of encapsulated organisms such as pneumococcus. When you do get complications initially, you look for sequestered infection. Sequestered means hidden. So empyema is one of them. And you can see the reverse D sign here. It's not that common, about 1% of people. younger usually. Streptococcus milleri is one of the common pathogens that causes it. Aspiration can be linked to it, and it's drug use. You should have a low threshold for transthoracic ultrasound and a pleural tap, even if the amount is small. Another sequestered infection are lung abscess. And again, the risks are alcoholism, seizures, and poor oral hygiene can be high risk for such patients. Anaerobes from the upper airway flora, aspiration link to this. And these are some of the pathogens that you can see when people have underlying abscess. Bacteroides and Fusobacterium are particular ones to look out for. They can develop B symptoms, and that could masquerade and mimic a lot of other differentials, going back to the art of medicine, lymphoproliferative disorder, for example, or mycobacterial tuberculosis. Extended antibiotics are usually required when you've got sequestered infection, and drain and surgery. People differ the number of people that would require surgical or pleural intervention, but I would say it's about 1 in 20. There's probably a lower threshold in hospitals that have more advanced modalities at their disposal. We come to the non-infectious bits. So it's the bit, it's the citrus fruits, the lemons and limes, and you put them on. So in those that end up having non-resolving consolidation, what was defined as pneumonia, chronic consolidation, about 1 in 20 will be neoplastic. So, and often the ones that would give you consolidation are bronchoalveolar cell, adenocarcinoma, when you get sort of subsolid component when they've had their CT scan to give you a clue. You can sometimes get post-obstructive pneumonia, sometimes gets carcinoid, and of course lymphoma as well when it comes to neoplastic differentials. Again, a busy slide sort of defines some of the common causes between neoplastic disorders, immunological disorders, drug-associated pulmonary vascular abnormalities. And I'll give some examples here. So this was a case of bronchoalveolar cell carcinoma. This was a case where we had, you can see the consolidation within the airspace of pacification, it's in the periphery here and there. And that was a case of cryptogenic organizing pneumonia. You get a shorter history of cryptogenic organizing pneumonia, but you always have to look for the eosinophilia. Because if you get an associated high eosinophilia without another explanation of, say, for example, an endotype of asthma, then you should think about chronic eosinophilic pneumonia. They usually have high eosinophil count, and it's a slightly longer duration presentation compared to COP. They respond almost similar in terms of treatment with immunosuppression. In this case, you can see the nodularity within the fissures. You can see that there is sort of widespread airspace of pacification in both lungs. This was a case of pulmonary sarcoidosis. There's some calcifications within the lymph nodes there as well. In this case, the consolidation with some cavitatory change. The patient had microscopic hematuria within their blood, and it turned out to be microscopic polyangiitis. So all of these things are inflammatory, non-infectious mimics of pneumonia. This was a nice case of amiodarone lung. So drug-induced is there's a few common culprits that you look out for. I always look out for them, particularly if somebody's got interstitial changes: amiodarone, methotrexate, nitrofurantoin, bleomycin, and tyrosine kinase inhibitors, particularly lately when they've been introduced a lot more in terms of targeted treatment for oncology. And in this case, the attenuation was quite high within that consolidation. And in that case as well, there was a higher attenuation within the liver and spleen, in keeping with amiodarone pneumonitis. And the patient, I think, got much better after the amiodarone was discontinued and had a course of systemic steroids. Vascular disease. So this is an example of what I was saying earlier in terms of filling defect plus the triangular opacity that you can see here, Hampton sign, where you get an infarct that then gets infected in the context of pulmonary embolism. So these are all quite common non-infectious causes of chronic consolidation. This was a sequestration, I think, from memory. Yep, so this was a ILS, so intralobar sequestration, intralobar in the sense that the part of the lung lies within the normal pulmonary visceral pleura. And if it's extra lobar sequestration, then it's an abnormal segment of the lung, completely separate, and enclosed within its own pleura. What's more important is to look for the feeding artery and the draining vein. That's important because then it gives you a clue. And sometimes with lobar sequestration, you can get consolidation next to it. So it looks like a dense consolidation. That's usually the place where you find it. And sometimes you get a heterogeneous consolidation right next to it, maybe due to subsegmental collapse and infection. That's one note that I found interesting over the years. So not all calm waters mean the storm has passed. So when you get improvement in symptoms as part of intervention or natural course of the disease office, we sometimes celebrate prematurely and say, great, the patient's better. But that false sense of security is something that you have to have in your armor as a clinician so that you don't get caught out. So this was an example where a patient had profound pyroxia of unknown origin, CRPs 230, 250, 300 at times, over a period of late December into January, February 2022, white Caucasian, had so many investigations. The only thing that he had a bit of anemia, B symptoms, he had a CRP that was fluctuating like this, his PET CT scan, although not reported. Paul Cadden, one of my colleagues, said, look at the cecum, it's a wee bit more inflamed. And when I looked at it as well, and I actually looked at the images itself, it was sort of ileocecal inflammation. White Caucasian in Perth, I was thinking, if this was in Iraq, I would have called it bowel TB. Interestingly, he got a levofloxacin for a hospital-acquired pneumonia, and he saw a big drop here initially in his CRP. And I said, let's not have celebration prematurely, and let's keep an eye on him. And indeed, his CRP went back up after he completed the course of levofloxacin. And at that point, and although there was lots of questions asked of the family, then his wife reported that she looked after her mum who had tuberculosis. He got treated for bowel TB, and this is the end result of CRP going down after he completed his treatment, which was a nice result. So in this case, the calm before the storm was the quinolone that gave us the clue. So there was an improvement, but you still haven't got the final picture yet. Sometimes part of the art of medicine is treating two conditions simultaneously, sometimes without realizing. So for example, I've had a patient who had CAP and an asthma exacerbation, gave them steroids because they were wheezy, but they actually turned out to have COP afterwards. And that's because we gave them prednisone, they got better, and they kept on getting that. And the prednisone was given for the wheeze, they had coexisting asthma. So again, systemic steroids, remember when you're giving them to people with asthma exacerbations, that there are a lot of non-infectious inflammatory disorders that you will be treating without realizing that you're treating. So just keep an open mind about that. My heartburn was better. So this was a case that had a long history. And I often, when I sort of try and look after patients in acute medicine, some of the registrars have worked with me, they'll see that I try and go into detail what the past medical history of the patient is. And everything is relevant for me. So even if they've had a history of Barrett's esophagus confirmed in the past, then I'd note that. And the reason being is that when I was asking them about the heartburn, they said, you know what, doctor, over the past 6 months, my heartburn is much better, but I'm just, swallowing is not as good. And sometimes I'm just shying away from eating anything that needs a lot of chewing. So that's what they put it down to. And that's because those who are in the gastroenterology field will appreciate this more than I. People who have Barrett's esophagus who then develop adenocarcinoma get a sphincter-like effect that compensates the existing sphincter. You get less heartburn, patients improving, there's less heartburn, but you get caught out because they actually have adenocarcinoma instead. So these were all examples of where patients are actually getting better, but because you have that in the back of your mind, are they getting better symptomatically? Why are they getting better? So it's not just getting better, I'm happy without an explanation. And then the common ones that we look for as when the storm has already arrived. So this is a 36-year-old lady with mixed connective tissue disease, and you see the nodular consolidation on the left, 2 months of cough productive, already had an HRCT on immunosuppression. the point that I'm trying to make for this is we're not going to start from scratch. We're not going to be waiting for week 4 and week 6 to see if it's chronic consolidation. There's enough alarm bells here that we need to expedite to look for unusual pathogens, look for non-infectious causes. So you jump to week 8 straight away. And so that was a summary of when you don't get people don't get better when they've got consolidation, whether it's infection or otherwise. Watch out for those who actually do get better, but it might be something else. And I put this acronym just to remind people. So when I get non-resolving pneumonia, particularly chronic consolidation, I would call it chaos. So you've got C for complicated pneumonia, and I've talked about them. So suppurative pneumonia, for example. Host impairment, and that's what I mentioned earlier in terms of risk factors in the host themselves. A for antibiotics, whether they're given correctly, they're given the right type of antibiotic. The organism is O, and are they resistant? Are there unexpected organisms that you have to think about? And then S for a second diagnosis, either additional to the existing diagnosis, say pulmonary embolism or cancer, or an alternative like COP, for example, chaos. So complications, complicated pneumonia, host impairment, antibiotic, organisms as second diagnosis. And with that, I thank you kindly for your attention. Hopefully it wasn't too long, and hopefully it was something that was useful.
Thanks very much, Mudher. Lovely, really nice. And I hope that there are some of the students I was teaching earlier on this morning about chronic infection who have come to the Grand Round today, because it's a really nice follow-on from what I talked about earlier on. And you've done a really nice job of making something very complicated.
It's all about jihad nefs, isn't it?
Yeah, jihad nefs, of course. You made a really good job of making it accessible to a whole range of people here. And I know there's plenty of our respiratory colleagues here who have learned a lot. I'm sure other people have as well. So thank you very much. I was reminded as you were talking that we did before Grand Rounds was Grand Rounds, and Ron McWalter used to host a medical meeting. Our old colleague Ali Al-Dabar gave a very similar talk about non-resolving consolidation. So that's good, probably 15 more years ago, and it was just really nice to hear you talk about the same topic today. Does anyone have any questions that they want to ask Mudher, or any comments? All of medicine sees respiratory medicine. It's 30–40% of the take. So I think that, we do, our specialty bleeds into many other specialties, particularly in general medicine. You talked a bit about mycoplasma, and Dave and I were just mentioning as you were talking that although it does classically not cause a severe illness, but more a protracted illness, and that multifaceted sort of bit of bellyache, bit of arthralgia, headaches, and then that protracted cough that goes on and on because of ciliary dysfunction. But we did see in medical HDU here last year, I would say 4 or 5 cases of severe mycoplasma pneumonia. Young people who were really sick, stuck on high flow nasal oxygen, CPAP, with some multi-organ dysfunction, perhaps not catastrophic and not needing ICU, but on the verge of it. And the 2 cases I looked after, we gave them steroids for the pneumonitis. And that seemed to be what turned them around. But epidemiologically, last year was a peak year for mycoplasma, so we shouldn't see much more of it for another couple of years if the textbooks are right.
Yeah, it adheres to epithelium. That's why it causes a lot of trouble. So that's a very good point, Tom. So it's not severe enough, but it can be really disruptive to the patient's period of recovery and them getting back to their usual life. Yeah, right.
We were just really struck by, I don't think any of us had seen such severe mycoplasma before, and there was just a little run of it. Very strange. Okay, so I don't see any questions in the chat. No one's got their hand up. People are saying thank you. And that's it. Lovely. Well, Mudher, thank you so much for offering us your slot today. I really, really appreciate it.
You're welcome.
Next week at Grand Rounds, Karen Smith is going to talk, who works in TASC, is going to come and talk about the NIHR Associate Principal Investigator Scheme. Get my teeth around all of that. And then as we move into March, it is International Women's Day, and we have guest speakers Lauren Shaw and Nikki Riding. There is an invited speaker via the Medical School University office, I think is speaking from the Middle East. Forgive me, I don't have here which country. I think it might be UAE, but I'll confirm later on who's going to be talking about scholarship. There is an enticing vacant slot on the 20th of the 3rd, where I have no speaker. So if anyone would like to give a talk, I'd be delighted if you get in touch with me and fill in that slot. And then rounding out March, Fiona Patrick from the major trauma team is going to speak about rehab of major trauma patients. The rest of the summer after Easter also looks a little bit bare. So if you know of someone who can give a talk, you'd like to give a talk, or you can think of a topic you'd like to hear about, please do get in touch and I will try and sort something out. So thanks very much again. Lots of thanks in the chat to you, Mudher. We really appreciate you. On a personal note, I'm so glad you decided to stay here in Tayside, and it really is our gain. And till the next time, everyone have a good weekend. Take care.